We're going to have a question and answer session now for the first panel. I'll also comment on the privacy issues. In New York State, we have something called Health E-Link, and it's where the electronic health records are actually, they're hooked to a statewide database. And it turns out that the patient cannot opt out of having information put into that shared statewide database. They have to authorize a physician to take information out of it, but they have no control if they see a doctor who uses electronic health records and is hooked up to the Health E-Link system. It's all their information's automatically shared. Doesn't matter what their wishes are. So let's take a few questions.
Dr. Huntoon, thank you very much. I think the survey that you're proposing for the potential Medicare recipients to find out what your feasibility is of getting off Medicare is great. However, I would caution that the language in there, I'm from Texas, and in Texas we have, the medical board has set rules against proposing that you're providing better quality or higher quality. These subjective terms will get you in really hot water in Texas. I'm not sure about other states, but I noticed in your language in the survey you said, would you like better quality or higher quality? I would suggest maybe modifying that to say, would you like to spend more time with your doctor?
Yeah,
Things
good
like
point.
that.
Good point.
Hello, my name is Dr. Sam Gupta. Excellent talks, all three talks, beautifully done. The out-of-network point that was raised, in my practice in Minnesota, when I practiced in Minnesota, one of the largest insurers, we were out-of-network with them, but you would think that you could bill them what you felt was a reasonable fee, which we followed the Fair Health guidelines. For those of you who are aware, we billed under, or much below those guidelines, but the insurer took it upon itself to reimburse us at a Medicare rate, which was absurd. I don't have any contract with the insurer. The patient has elected to have the procedure done at my office. They asked me to send the records or give the patient a copy of the records. The patient exercises his or her right to obtain reimbursement from the insurer for an out-of-network provider, but the insurer says, according to their policy, they pay equivalent to what Medicare would pay. And so my question to you, I guess, is have you experienced scenarios, or have you been asked questions or personally experienced anything like this, and what kind of law would allow them to do that?
That's a battle that goes on in many specialties in many areas of the country, and you have several options when the insurance company does that. One option is to collect the balance from the patient, in which case the patient will get the insurer involved, and the insurer will then feel compelled to deal with you about that. Another option is to sue the insurance company for the balance, particularly if it's an emergency service, which I think some of your services may be, emergency services, and the insurance company may be obligated to pay for emergency services, or even if it's not obligated by law, you have a claim under unjust enrichment or quantum merit to recover the value of your services, fair market value of your services, not the in-network amount, but what you think is reasonable. You have a legal argument to recover that from the insurance company. You can get into litigation with the insurance company, and we've seen physicians win those cases. I've won some of those cases. So I would say those are your two primary options. One is to collect from the patient, or try to collect from the patient, in which case that will draw the insurance company back into it, and they will try to protect the patient in some way. And the other is to go after the insurance company directly, legally, with your claim. You provided the services. The patient was covered by the insurance company. Your understanding is that you were going to get paid a reasonable amount for your services when you provided them, and that's a standard legal claim for unjust enrichment if the insurance company keeps the money and does not pay you.
Other questions? Okay. And over there.
Larry and Andy, you both mentioned that you're less likely to be sued if you're in a cash practice. So do you know if anybody's tried to approach the liability insurance companies to say that they should ask that and when assessing your risk and lower our premiums? And that might be a good way to also encourage other doctors that it's a viable option.
I have, and the insurer expressed no interest in even looking into it.
I think they don't have a lot of data on cash pay practices, so they don't know what to do with that. You usually, at least in DPC, what happens is your patient panel is smaller, and that's literally fewer potential plaintiffs, so you should at least get a discount based on that, and that's often true for a lot of other cash pay practices as well.
I hear it. I'll come back to you. Hello, Michael Robb, Phoenix, Arizona. I would second that. I also tried to ask the malpractice carrier in Phoenix, Arizona, and inform them about a low risk that they were undertaking, since I was completely opted out. And they offered me a part-time rate. And they said, if you work 20 hours a week, we can give you a part-time rate. That's one way you could get that adjustment. But then, since I'm in a solo practice, then they said that you're pretty much full-time because you're always on call every day, and I just couldn't meet their part-time 20-hour requirement. And so there is no other third option, Janice, as far as we know. And my question is for Phil and Andy. When you suggested that there are numerous ways that a DPC doctor could still find other work, such as moonlighting and correctional care, is there another option if, let's say, a physical therapy office or a PhD in charge of a rehab center, or someone who is not an MD but wants to help patients privately, and he's not contracted with Medicare or insurance companies either, can he hire a DPC doctor to see patients and then pay, either pay that physician through private income, or the physician just bills the patient privately, but the physician is considered a consultant?
Are these Medicare or non-Medicare patients we're talking about?
These would be all ages. And if the patient happened to be Medicare, they would obviously sign an opt-out agreement because that DPC doctor would presumably be opted out. But if
Well, that's the key, is that he would have to be opted out in order to do that for Medicare patients.
I don't think in that instance, I don't think the use of the athletic trainer or whoever's running it as the top entity, I don't think it changes the legal structure really. I think you have the same burdens that you already had in terms of Medicare opt-out obligations and such. The most common kind of mistake I hear of is, and people are often told this, is that several physicians debating DPC and opting out, they say, well, it's okay if I opt out, I can still go work as a hospitalist because they're just going to bill under the group's Medicare number and not mine, everything's going to be fine. And it doesn't work that way. And they might get away with it in the sense that nobody notices, but it's not legal per the Medicare provider manual.
There have been prosecutions of physicians who have worked for chiropractors. Those arrangements are viewed with great suspicion by prosecutors, and I think the idea of a physician working for a physical therapist is something that just seems suspect. I would be very careful and hesitant before agreeing as a physician to work for a non-physician, particularly if there's billing of any government system or insurance companies.
One more comment there also, for as far as chiropractors and physical therapists, they're actually not allowed to opt out of Medicare. So that's the other kind of bizarre problem with that relationship.
So I have a comment and a question. I'm a solo practitioner, psychiatrist, almost my entire career, except for some forensic work that I do. The billing that I'll do with insurance is we will submit to insurance for reimbursement, But for the most part, the patient pays me at the time of service and pays me my fee. The question I have, and which I've been doing my entire career, is I do adjust my fee sometimes. I'll have a patient who's been with me for 10 years, they've lost their job or whatever. So I've never thought that there was anything wrong with that, but I'm asking, is there something wrong with that? The patient's paying me directly, but we are submitting CPT codes. We're giving them papers and CPT codes for them to get reimbursed. So it is my regular fee, and then it's adjusted. Is there a problem with that? That's number one. Then my comment on the insanity, which is what this conference speaks to, of the entire world that we're living in, is the concept of don't do nothing, do something. So in the state of New York with the opioid crisis, the state of New York now requires that physicians only write paper prescriptions. In the state of Connecticut, we've now moved where you cannot write paper prescriptions for opioids. So
Which is true in New York State, too. You cannot, unless you have an exemption.
So you can't write. So,
You cannot
so
write
that
paper
goes
prescriptions in
against
New
the
York.
Same thing in Connecticut. I currently have a waiver. I assume that's going to go away very shortly. But that goes against your privacy point that you were saying for somebody who you have to write it, an electronic prescription. So the question first, is there anything wrong with what I was doing, with what I'm doing? Am I adjusting fees?
I don't see a problem with adjusting your fees based on the patient. That's part of the reason you want to do private medicine, is that you have the flexibility to do that. There used to be fear that you couldn't offer cash pay rates below Medicare. That's all changed. Anybody who's telling you that is looking at outdated law. I think where you could get yourself in trouble is if you wrote down a CPT code and wrote down your standard price of $200 and give that to the patient, and the patient's seeking reimbursement from the insurance company when in reality they only paid you $100. As long as you don't have that scenario where it looks like you're working together for insurance fraud, then you should be okay.
I'll have to double check that. Thank you.
I mean, you do have,
Thank you, by the way. This is fantastic.
oh, thank you very much. If you've signed insurance contracts, you do have to be, you have not. Okay, that takes care of that. Perfect.
Andy, I just wondered if you use the no involuntary servitude part of the Constitution in that reimbursement case with Medicare?
I did, actually. I said that someone cannot be forced to work for free. And the position of Medicare is if you miss that notice for revalidation, or if you get the notice and you don't revalidate properly, they insist that you have to work for free until your enrollment is revalidated. And I made that argument. You're not required to work for free. And we did get CMS to change its policy for this particular physician. But if you go on the internet and you look, their general policies, if you have a lapse period, you're working for free and they're going to refuse to pay you. That's what their official policy is. And that's what we've gotten to. That's what we've gotten to in this country, where the bureaucracy is actually saying, in certain circumstances, you have to work for free. I mean, how outrageous is that?
You know, going back to this chiropractor thing, I mean, I'm used to looking at the dark side, and if you're willing to go over to the dark side and think about it, a lot of hospital administrators dictate medical care to those hired physicians working for them. So I'd take a chiropractor over an administrator any day, and that's what we're doing on a daily basis here in America, working for administrators. And if you're looking for new jobs outside of DPC, you could go to the dark side and be an administrator, or go to the insurance company and be one of those guys on the phone that reject everything that comes along. I mean, there's a lot of this administrative dark side out there that one could tap as extra income. More morally inclined would be just go work construction, I suppose. But that's a question for you. I mean, working for the man.
Yeah, I hear you, Paul, and I just caution everybody that there are limits to logic in dealing with some of these prosecutors. I mean, the whole notion, they're going after Dr. Ghosty in New York, and the reasons they give, and you look at every reason, you say, that's illogical. I mean, you're going after him because he was the #1 prescriber of opioids. There's no logical basis for going after someone because he's #1 prescriber of opioids. It's always a #1 prescriber of opioids.
I would say the irony behind corporate practice of medicine laws is pointed out by your comments. You know, the point of those is that no corporation should be telling a physician what to do. And a lot of states have interpreted them in weird ways. Some of them have abandoned CPOM entirely for better and worse in some instances, but the irony in almost every state is they carved out exceptions for HMOs and hospitals, which are the two entities that are the most problematic when they tell a physician what to do. So the problem was not with a small administrator who happens to have some ownership in a physician practice where there's 3 physicians that own it, want to share some, ownership there, which is what it often prohibits. The problem was with the large HMOs, and routinely they have exceptions.
Yes, hi, Jerry Mealy. I am practicing direct pay endocrinology in Florence, South Carolina since about 2014. I'm a member for all those years. You helped me out a lot in the beginning. I'm here trying to refresh and get some great ideas. You answered some questions I had greatly up front. I appreciate all 3 programs. Just a quick comment. I was going to ask about better malpractice insurance rates, but I think you already got that. And then we had a comment about part-time. I just want a quick comment on what I happened to be in South Carolina. I did get a part-time discount, and essentially they limited it to only absolute patient encounters, not anything administrative. So in South Carolina, I am getting a part-time discount. It is helping me, but I did have to actually drop the other half of the insurance system they have out there, the patient fund. PCF is not mandatory, and what I was advised was that since you have a low patient panel and a very low exposure, you could drop your PCF if it's not mandatory. So I'm just doing basic liability with JOA. I have a part-time discount because I don't need to see that many patients at this point in time. Just a quick comment, something like that might be available in other states. And then a quick question, I guess, to Phil. Looking at these other opportunities, I'm still in a growing phase, believe it or not. Specialty has been very difficult to get off the ground in this market area that I'm in, but I'm still keeping at it. I love it. It's great. I was basically on the edge of burnout when I changed over to this, so it's been phenomenal for my mental health. Patients are doing tremendously well, okay? But getting people on board with it has been really difficult, especially in smaller market areas. You had some great suggestions for part-time stuff to kind of beef up your income. I don't know how it would apply to me in endocrinology, but have you had any experience with the locum tenens market and a way for, and I'm opted out of Medicare, no Medicaid, no contracts with anyone whatsoever. And I've kind of looked at that, but I'm not sure how to break into that if it's even possible.
Most of the locums agreements, they have an agreement with you, and then that locums company has an agreement with the insurer that only applies to care that was provided under that locum setting. So it shouldn't interfere with you seeing private patients that happen to be insured by that company in your own office. So if you're able to arrange that, that'll work. Your usual holdup is that they're going to want you to be a part of Medicare for those things. I would say as you're growing your practice, I don't know what your model and design is at the moment, but in endocrinology, I think that would often be a DPC type relationship, I would think.
It's
a monthly fee. You're seeing people on a chronic basis.
Monthly membership fee, a visit fee, low visit fee, and initial consult rate. Yeah.
And you're probably going to, even if you didn't want to, I'm guessing you did, but you're going to have incentives from your patients because they're going to want you to do everything you possibly can, and it might well be stuff you didn't do routinely before as an endocrinologist?
No, actually that's been pretty much kept to a minimum. Most of my patients still have a primary care physician. I encourage that, so I do not practice really primary care. I mean, I'll take care of things I might not have done in the past just to tide them over to get back to their medical doctor, but not extensively at all.
Okay.
On the malpractice front, we've had members who have gone bare, as the expression is, and just gotten rid of malpractice. And some of them will disclose that to patients, just say, I don't carry any malpractice insurance. And I've never heard of any of them having any problem. I mean, an attorney is unlikely to sue a doctor who does not have malpractice insurance. When doctors get sued, they're going after the coverage. So it's something to consider. And you would want to look at how you hold your assets. In most states, your retirement assets are completely protected against any creditor or judgment. So if you're holding most of your assets in some sort of retirement, like IRA or KEO or 401k plan or whatever, that's going to be protected against creditors. If you're married and you hold assets in such a way with your spouse that's protected, I mean, look at your asset protection and consider dropping your malpractice coverage. It's not required in most states. Some states do require it, and some hospitals will require it. But most states do not require malpractice insurance, and if you don't need medical staff privileges, you could consider dropping it.
Some of them have an indirect way of going about that. I think, if I remember correctly, in West Virginia, they have a medical malpractice non-economic damages cap, but the cap only applies if you have insurance. So be aware of that.
Hi, my name is Brian Jabala. I'm an orthopedic surgeon from Florida, and this is my first meeting. And I'd like to say that I'm really impressed with the talk, and that people are having the courage to discuss these issues, because at most of the meetings, at least the academic type meetings that I go to, we never have the courage to discuss these type things and get them out on the table. And thank you very much for putting this meeting on. My question is about Medicare HMOs in Florida. They seem to be very prevalent in Florida, and I don't participate in many of them, and so we tend to treat those patients like private pay patients, but I am a participating physician in Medicare, so I wonder if we try to charge the Medicare rates. Are we bound by the balanced billing law with patients that are privately contracted with Medicare HMOs outside the Medicare system?
Well, you said you're a participating physician in Medicare.
I am, but I don't take Medicare HMOs. So, for instance, United Healthcare has a Medicare HMO, and so we technically don't participate with their Medicare product. Same thing with Humana.
I don't know.
Well, but if you're in Medicare, you're going to be bound by the Medicare rules, and you're not going to be able to privately contract with patients who are Medicare beneficiaries. So I think the answer is you would be prohibited from charging private rates to those Medicare beneficiaries who are Medicare HMOs, because you're enrolled in Medicare. Now, if you opt out of Medicare, then you would be able to charge your private rates.
I think a potential source of confusion here might be if you're reading about some of the larger DPC practices like Iora Health. They do DPC, but with Medicare Advantage plans. And those are designed, the Advantage plans at least, are designed to cover things that Medicare doesn't cover. So technically those physicians are still in the system, but they have an Advantage plan that's paying that monthly fee. But that, in those settings, you still don't have the ability to have full flexibility to privately charge the patient. You could just get something different arranged with the HMO over and above if you want to.
These are Advantage plans, and they generally don't want to negotiate with us. They say, well, we have our physicians, and the patients say, well, I want to come to see you, and we have them sign an ABM, and we charge them Medicare rates, but and they pay cash.
Your patients might like, that's another sticky area we didn't get into. But for an Advantage plan to cover something, they usually need some sort of notice from Medicare that Medicare is not going to cover it. And so the question that I sometimes get that people might be thinking right now is, hey, if I've opted out, can I provide the patient with a letter about that, and then the patient uses that to seek reimbursement not from Medicare, because they promise they won't do that, but from a Medicare Advantage plan? And the answer is hypothetically yes, but those Medicare Advantage plans won't usually pay out unless you have an official denial letter from Medicare, which you can't get if you've opted out because you promised not to bill them. So I'm probably skirting your question a bit. But
What, it sounds like it's not a straightforward type thing. Okay, well, I appreciate the attempt at an answer anyway. Thank you.
Yeah, we can follow up on the break, too. If you're going to be around through dinner, we can chat further about that.
The Medicare HMOs changed the rules. So the rules of Medicare don't apply to them. They control patients, they shunt them, they steer them wherever they want them to go. And the people who participate with Medicare HMOs are generally the larger groups and the hospital employed groups, because they're able, with clout, they have larger numbers of patients, and the HMOs will give them a better rate. But with small practices, they don't. They will give you maybe 85% or 90% of Medicare, but then the other groups, I even know of one doctor who's trying to get 110% of Medicare with a Medicare HMO. But they're changing the rules, and then if you're outside of the Medicare HMO, they shunt the patients. Even if you've taken care of them in emergency rooms, they send them somewhere else. And so is this fair for Medicare to be allowing these HMOs to change rules that then don't apply to the physicians taking care of them? So if the physician is able to charge a reasonable rate for services in, say, an emergency room or somewhere, then it seems to me like you shouldn't be bound by Medicare rates. The other thing that I'd like to mention is that these insurance companies, if you don't participate with them, they used to pay at 100% in many situations, but they don't anymore. They're only paying 10%. And I'm talking about commercial insurance, not Medicare. They're only paying 10% anymore. You can't sue them because you don't have a contract with them. The patient can sue them, but they don't. Instead, they'll go to the newspapers and they'll make you look like a bad doctor because you're not participating. While at the same time, the insurance companies are paying many times less than Medicaid rates. And what the insurance companies are doing, Anthem in particular, is they're going to the various states and they're getting all this public attention to these problems of these doctors who aren't participating. And then the next step is to go to the legislator and say, we need this legislature, the state legislature, to pass laws to limit this like they've done in California. So this is sweeping the nation. And it's all because of price controls that originated in Washington, D.C.
Yeah, those are excellent comments, Ken, and we're fighting those, we call them surprise medical bill laws, and we've successfully blocked them in some states, and we're suing to overturn in California. But I do want to mention, Ken, you could sue the insurance company and the patient as an out-of-network doctor. You could sue them for the services, the value of the services you provided. And I would encourage you to consider doing that. Sue both the insurance company and the patient. Even though you're out of network, you provided services, and the insurance company is being unjustly enriched by not paying you for the value of your services. Well, I'm suggesting that you can, Ken, even though you don't have a contract. There are some situations where you can sue somebody for the value of the services you provided, even though you don't have a contract. If you allowed someone to paint your house and you never signed a contract with that person, and you never even said how much you were going to pay them, the person who painted your house could sue you to recover for the value of his services in painting your house. It's a little unusual, but I'm just saying it is legally possible, and there have been recoveries on that, and I've won cases on that, so it's something to consider. I'm not saying it's easy. I'm not saying, and your complaint is well taken. I'm not saying it's easy, but right. Well, we'll talk about it afterwards.
Why don't we take two more brief questions?
Hi, my name is Diana Zhang. I'm a geriatrician from New York City. I have one question is, I have a contract currently with Medicare, and I also take Medicare HMOs, like United Healthcare. If I opt out of Medicare, is that automatically also opt out of Medicare HMO?
Yeah, I think the answer is yes. I mean, you cannot receive payment either directly or indirectly through any other Medicare-related program if you're opted out. So I don't think you can remain in Medicare HMOs if you're opted out of Medicare.
I'm fairly certain the Medicare Advantage contracts would have some sort of requirement that you're accepting Medicare as part of that payment.
I mean, like we bill Medicare, there are a patient with Medicare, straight Medicare, we bill Medicare. If with a Medicare HMO, we bill Medicare HMO, like they're like United Healthcare or Health First in this kind of plan. But like say if I opt out of Medicare, do I need to inform all the rest of the company, Medicare HMO company, to tell them I'm opt out Medicare?
I would think the answer is going to be yes, but you need to look to the terms of that contract. I don't know of anything in the Medicare provider manual that specifically addresses this question, but I'm pretty sure the answer is yes.
So I need to inform all different companies on.
Yeah, all the Medicare Advantage plans, yeah, I would do that.
The other quick question is for Moon 19, you mentioned about the hospice program and the PACE program. And I understand PACE program and the hospice is funded by Medicare and Medicaid, right? Are they going to hire a physician who is opt out of Medicare?
You can, it's administrative work.
Only
technically.
administrative work.
Yeah, technically, most of those hospice director positions are administrative work.
But they do see patients too, hospice patients.
If you're going to see them and charge Medicare, then that's a different issue. But if all you're doing is coordinating because most hospice programs are paying you purely for an administrative role. I mean, if you take a step back, hospice doesn't need to pay you to see a Medicare patient because you were historically always going to bill them that way anyway. You were going to bill Medicare. But if you've got a private agreement with those patients, you can do that, and hospice can still pay you their administrative fee.
But what
Just
about
oversee
PACE program? And I know PACE program, they hire physician to see the patients with under the PACE program.
Right. I've actually gotten different answers, and I called up straight to the top of PACE on this one.
Yeah.
So they sometimes bill Medicaid, they sometimes bill Medicare. They never use fee-for-service coding. So I highlight it because it is very DPC-like. Okay, because you don't have to deal with the coding and all those headaches, and you kind of get to have a longer visit with the patient just like you want. And whether or not you can do that opted out is a little bit of an open question with PACE.
Yeah, Phil's point's well taken. It's going to depend on how they bill for those services. If they're putting your name on it as a physician and they're billing fee for service, you're not going to be able to do that as an opted out doctor if they're billing Medicare. But if they're not billing that way, if they're just paying you a salary, it's mostly administrative, then it's probably not a problem.
Right.
Okay, we're going to have to preserve some time for the break here. Everybody's going to be available at the break if you've got more questions.